Assalamu alaikum wa rahmatullahi wa barakatuh. Just because we are running of time, I'm glad to be with you discussing the highlight from last year ACR Convergence 2023. And I'm happy that having a good number of attendees now in the last day, or the session before the last one. So I have nothing to disclose. When I was asked to prepare Best of ACR from the ACR 23, actually I went, they knew that I'm going to attend the conference. That's why they gave me maybe this topic. Anyhow, I went through the abstract just before attending the ACR, and I found more than, you can see, approaching 300 abstract in lupus, including adult and pediatric, and cover several, of course, aspects of manifestation, treatment management, pregnancy, and so on. So, just highlighting adult-related lupus, I found 169, and then I try to choose the likely clinical, important for us as a clinical application, and the novelty and new therapies. And I attend actually some of the plenary sessions that related to this session. I saw them because they are talking a lot about ChatGPT and can help us in preparing the slide and catching this update. I open يعني فتحت لنفسي حساب قلت خلاص خليني اتطور مع الناس وكذا ودخلت قلت يلا I asked specifically about the new therapies promising in that presented in the ACR, and this is what they give me actually, just a title and quick review. But then I go further, what is the most informative about update from lupus nephritis and the other, and they give me just like a quick summary. What they want from me, because we have to talk together, then I have to put everything. I have to put all of these 169 slide abstract, and then they can choose for me. So I found it difficult. I just stick to what I attend, and this is the abstract that I'm going to talk to you about it, because this is it's help us during our practice. The first abstract about hydroxychloroquine. This is our old drug. We use to do it, and from all recommendation, we know that the best dose is 5 milligram per kg, and then toxic if it is more than 5 milligram for the eye. But what is the therapeutic range, and whether this therapeutic range is essential for reducing the activity of lupus and reducing the severity? So the objective of this study to define the reference range of hydroxychloroquine in the blood level with upper and lower boundary of efficacy, and to see if it has reduced the odds of active lupus. And what they did, they extract the blood for hydroxychloroquine level. At the same time, in the same day, they assess the activity of lupus based on SLEDAI, and they then come up with this range of, you can appreciate it here, the level of ranging from 750 to 1200. This is the range where patients benefit from the Plaquenil and improving the SLEDAI, as well as without toxicity. At the same time, any dose above 200, 1200, it will be of no benefit and more of side effect. What also? They examine also the physiological and social factors that determine the likelihood to achieve hydroxychloroquine level. And they come up with factors that lower the odds of achieving level within therapeutic range, which is Black race and Hispanic ethnicity, and barrier to social determinant of health. And factor that increase the odds of achieving level is 400 milligram, and they found it up to 26 times higher the odds ratio of therapeutic level. Also, factor associated with supratherapeutic, and this is very essential. So any patient with renal impairment, especially CKD more than 3, they have higher risk odds ratio of having toxicity or high level of hydroxychloroquine, and 400 milligram, of course, 6 times higher odds, and acute weight loss, it will increase the odds ratio. So we have to be careful in our patient on hydroxychloroquine with these three factors. Maybe we have to measure for them the level of hydroxychloroquine. And they come up with this conclusion that it's better in the clinic to assess the hydroxychloroquine level. And if it is less than 750, check the interaction, adherence, weight gain, and dose. If it is more than 1200, check interaction, weight loss, dose again, and GFR. And then adjust accordingly. And this is the summary of the study. An effective range of hydroxychloroquine level is 750 to 1200 nanogram per ml. High-risk group who will benefit from hydroxychloroquine level monitoring for optimal hydroxychloroquine is group with higher non-adherence, CKD, and weight loss. Then I choose some of the medication because there's a lot of phase 2 trials. I found this interested and about cutaneous lupus erythematosus, all type of cutaneous lupus, and they did CLASI for them with new modality, mode of action, which is deucravacitinib. It's an oral selective tyrosine kinase 2 inhibitors, 4 groups with 4 doses. And as I mentioned, all type, and they have to have SLEDAI more than 6 with arthritis with no major organ involvement. And you can appreciate here from the graph that there is a good response with, you can see here in subacute lupus, almost 100% they improve on a dose of 3 milligram. And all of them, they have clear improvement at 28 and 48 weeks. And they come up with a conclusion: patient with moderate to severe skin involvement at the baseline in phase 2, basal trial treated with this deucravacitinib were more likely to sustain CLASI 50 response than patient receiving placebo, and were able to achieve more than 70% reduction in CLASI activity score from the baseline till week 48. So we're waiting for now phase 3. Coming to another good thing about the combination, because still there is a lot of mode of action studying. There is a good number of abstract about upadacitinib, but they put high dose. So what we use in RA is 15 milligram. Here in this study and the other abstract, they use 30 milligram. What's attractive in this study is a combination. So they did 2 different mode of action: tyrosine kinase inhibitor, which is ilsubritinib, used in malignancy, approved for lymphoma, and combined with upadacitinib. And they have 4 group of patients, where around 90 patients in each group. They use either placebo, monotherapy, combination therapy. And the primary endpoint is the proportion of patients have respond, mainly SRI, at week 24 and persistent at week 48. And it was clear both in the combination as well as in upadacitinib 30 milligram achieve the objective. And this graph show you that whether it is combination or upadacitinib, they are equivalent and much of course better than the placebo. And they conclude that this combination, what they call it ABBB, showed as well as upadacitinib 30 demonstrated significant improvement in SLE disease activity and flare reduction with acceptable safety through 48 weeks, which is strange because we know that some of us SLE patients, like 20 to 30%, they might have an antiphospholipid. They didn't comment in the study about this thing, whether they exclude them or not, but the outcome was fine. So we're waiting for phase 3. Very nice topic they presented, and there are multiple abstracts about it. Time to consider sodium glucose co-transporter 2 inhibitors in management of SLE. And as you know, this SGLT2 is used by our colleague in endocrine and internist for management of type 2 diabetes mellitus. What they did here, they collect all patients from their, what they call it, database. They are on SGLT or the regular DBB4 oral hypoglycemic, and they found, which is a huge number, you see, SLE patient of 96,000 SLE. Out of these 96,000 patient SLE with diabetes, 25,000, and those on SGLT 400, and in the other form of oral hypoglycemic 890, and further sub-analysis of patients with lupus nephritis and diabetes on SGLT1 were 140 compared to 270, and they come up with this outcome. So SLE patient on SGLT, they have reduction of MACE as well as several forms of thrombosis, significantly. Actually, it's not significant, but the number-wise is higher than patient on other oral hypoglycemic. And what is interested that patient with renal involvement, they have less likely to have lupus nephritis if they are on SGLTB with a hazard ratio of 0.7. And this effect was more efficacy in lupus patient with nephritis on this medication. The reduction of MACE in 20, you can see, 9 compared to 20 with with a hazard ratio of 0.5. And again, further, especially in patients with renal problem, they have much better improvement as well as less thrombosis. But of course, we know that this medication, because it acts on the proximal tubule, it can affect the glucose and more infection they are having. So the conclusion of this study, in this cohort of patients SLE who initiated SGLT2 have a lower risk of MACE and renal progression associated with this medication, suggestive of cardiac and renal benefit, as have been observed in other, type 2 diabetes in general. The finding indicate that potential role of SGLT2 for our patients, so it's time for us, for any patient with diabetes, to start this for them. At the same time, we have another study by Prof. Michel Petri, and in this cohort of 45 patients, they follow up. They have a good follow-up, of course, like 3 years before starting SGL2, and then 1 year later. And what they found, there is a reduction. These patients on SGL2, they have much better in a form of less likely to have progression in their renal disease, as well as if they don't have renal, less likely to have lupus nephritis. And so maybe for us, it's a time, to use it to our patient. Now, another hot topic during the ACR is the steroid dose, not only in lupus, in RA and other form of vasculitis. But in lupus, there are two presentations. The first one by Delera, where what they did probabilistic matched from two major studies, you know it, the ALMS versus Aurora, and they did this probabilistic match regarding the duration of SLE, the albumin level, uroprotein creatine ratio, C3, C4, double-strand DNA. Then they have this match group from these two studies, and they compare, because we know that in ALMS study, they use high dose of 60 milligram plus high MMF of 3 gram, compared to the Aurora, where we have the lower dose of steroid of 25 milligram, MMF of 2 gram, plus, of course, voclosporin. And you can see here in the graph clearly the difference in the dose of steroid, and even during the tapering. And what they found that at 6 months, 9.4% patients on ALMS study were on a mean dose of 7.5, compared to 85% of patients on Aurora reaching to this. So quick tapering with equivalent outcome. So the outcome, whether you have the high dose or low dose, were same regarding the kidney. And you can see here that uroprotein creatine ratio was even better improvement in the Aurora group, where they are in lower dose of steroid. So they come with this bold recommendation that voclosporin-based triple immunotherapy regimen should be considered as an initial approach in our patients with active lupus nephritis. The other one presented by Saxena with, and this is from New York group, where they compare patient with initial glucocorticoid, whether it is small or large dose, but they review in the standard of care regimen studies where they have on top other medication like Belimumab, Voclosporin, and so on. And here they make the comparison between these two studies, whether it is low dose in several studies, as you can see, Voclosporin phase 2, Voclosporin phase 3, Obinutuzumab study, and Anifrolumab study, where they use a low initial dose compared to these studies with high dose plus standard of care. And just to mention that those on small dose of steroid, they give them pulse steroid for 3 days. What they found, the outcome of the renal outcome, complete renal response was equivalent, whether it is high dose or small dose. Side effect, much more with those on high dose. Infection, more with high dose, but the outcome was equivalent. So maybe it's a time for us to use the smaller dose, and this is what we put actually in our Saudi recommendation for lupus nephritis. So the conclusion of this study that based on the data pooled from multiple published trials utilizing standard of care, there is no significant difference in renal response between patients receiving IV steroid followed by low dose prednisolone compared to those receiving high prednisolone dose as initial induction. Serious adverse events were much on those with high dose. One study about Anifrolumab, I think it was discussed maybe in the lupus session early in the first day. I will not go through it completely, but interested about this study. They follow their patient not because of renal, mainly because of non-renal cause. But what they found, those patients in Anifrolumab, they are less likely to develop severe or lupus nephritis over 4 years. And the conclusion that in the subgroup of patients with renal involvement at a baseline, more patients treated with Anifrolumab remained in a study and achieved SLEDAI-2K renal improvement compared with the placebo over 4 years in this TULIP trial. And of patients with no renal involvement at the baseline, fewer patients had new renal activity with Anifrolumab compared to the placebo in all time. I don't know about the time, but if we have time. Another thing, كم باقي؟ 2 minutes؟ طيب خلاص كويس. ما كنت بقول لكم على كارتي بس بلاش كارتي. So we'll just do study about how to usually to assess the response in lupus nephritis, 24 protein creatinine ratio and eGFR. But here it's time to have other parameter to use. What they found several actually abstract about proteinase 3 cell abundant, because it was found that this proteinase cell abundant higher in patient with proliferative lupus nephritis. And the persistence of urinary proteinase 3 at 6 months and at 12 months, it predicts kidney function loss at 3 years. So they conclude that proteinase 3 cells are abundant in lupus nephritis, and most of these proteinase 3 cells are in tubulointerstitium, but at higher density in the glomeruli in the proliferative class. Proteinase 3 positive cells are strongly associated with histological activity. Their therapy characterizes more aggressive phenotype. So maybe future-wise we can test our patient for this. And another study by Michel Petri group, again, they assess different parameters, including interleukin-6, proteinase 3, and they come up with a conclusion that proteinase 3 cells are abundant again in this patient with lupus nephritis. And there is association between urinary proteinase 3 and the histological activity, suggesting that intrarenal proteinase 3 cells are actively degranulating and therefore likely inducing kidney damage. And there are ongoing thinking about of this finding that we might have nominate proteinase 3 cells as a potential therapeutic target. One study, nice study about the pregnancy, عشان نقفل, regarding the risk of thrombosis and pregnancy. And in general, they study the risk of thrombosis in pregnancy with autoimmune disease, and what they found that most of the risk of thrombosis was in SLE patient. And as you can see here, that cardiovascular risk occurred in 2% of 19,000 pregnant women with autoimmune rheumatic disease. 25 to 30 of these were postpartum, and most of them SLE patient. No time for CAR-T, so CAR-T therapy, because they mention a lot about CAR-T therapy. And the good thing about this one, there is 1 year follow-up with full remission, absent of correction, negative anti-DNA, NA, and complete symptoms. And the things about this abstract I selected, that it will not affect the vaccination. So even if it is given to the vaccinated people, it will not affect the immunity and the infection. Just the conclusion here, just to see the improvement. And they found that CD19 CAR-T cells therapy led to sustained disappearance of autoantibodies in SLE patients, while vaccination response remained stable. And this observation suggests that the main cellular source of autoantibodies in SLE are CD19 positive plasma blast, which are depleted by CD19 CAR-T cells, while antibody related to vaccination response appear to predominantly stem from CD19 negative plasma cells. So in a conclusion, ACR23 appeals that for extrarenal, we have to optimize what we have, use hydroxychloroquine level to optimize the efficacy, maintain anifrolumab if your patient on it. And it seems to be in the near horizon, we'll have rationale about targeted to pathological pathway. In the renal, optimize what we have about the dose of steroid. We have to better to use the lower dose. Combine MMF and voclosporin, and think of SGLT2 inhibitors for your patient, SLE with diabetes. And in New Horizon, urinary biomarker to predict long-term outcome. Thank you.